Okay, we're just waiting while people come in, and then we'll go through the rules of engagement. Okay, so the attendee rules of engagement. This webinar is being recorded. No one can see that you're attending unless you'd like to ask questions. So if you'd like anonymity during the question and answer session, please tick the box to send anonymously before sending your question. We hope to make this webinar as helpful to you all as possible, so please do ask your questions in the Q&A section. You may ask the question at any point, but they will be answered after all the talks. If we don't get through your questions in the allocated time, 45 minutes to around an hour for this evening, we'll answer them via email after the session. So the agenda for this evening, I'll be doing a quick welcome. Dr. Paul Le Roux from Cape Fertility Clinic will be talking about male fertility. And Chris Lawson from the IVF Dad podcast is going to be talking about their journey through infertility. After which we'll have a question and answer session, and then we'll wrap up. Okay, so thank you to everyone for joining us on our third webinar for Reproductive Health Month 2021. My name is Saskia Williams, and I'm the founding director and CEO of IFASA. I'm proud to be bringing this Reproductive Health Month campaign and these webinars to you in association with Michelle and Lucia of House of Fertility Media, as well as the IVF Babel Africa team. We are bringing you webinars every Tuesday and Thursday evening throughout February, featuring local and international specialists and speakers. We are also running a campaign for early diagnosis of infertility, and participating clinics are offering 25% discount on their initial consultation and scan fee. So please do check out our Reproductive Health Month website for further information. It's just www.reproductivehealthmonth.co.za. So let's get started on tonight's lineup. Our first speaker is Dr. Paul Le Roux. Dr. Le Roux is a fertility specialist and CEO of Cape Fertility Clinic. He's going to be covering all things male fertility in this session. Over to you, Dr. Le Roux.
Thank you. Okay, just getting my slides. Okay, good afternoon, everyone. Can you hear me okay, Saskia?
Yep, it's all good.
Thanks for my slides. So, yeah, good afternoon and welcome to the session. I hope you enjoy hearing about male infertility this afternoon. And I work at a private fertility center called Cape Fertility, and we do all aspects of fertility treatment. And today I'm going to focus on male infertility and give you a little bit of a medical background about how we investigate patients and how we manage them. And I'll be very happy to answer your questions afterwards. You can post them, and then Saskia can pose them at the end. Before I kick off, I'd just like to thank IFASA and the other organizations that have been involved in Reproductive Health Month. It's really important that we bring awareness to patients so they feel you know, that they can come to fertility clinics and we can help them with these problems, because it is very distressing for couples when they can't have a child when they need to. So we really are here to help, and I hope you enjoy the session. So the clinic I work at is in Claremont in Cape Town, and we do approximately 1,000 IVF treatments per year. And this is a wonderful team I work with. We have people who work in the laboratory, and nurses and doctors and administrative staff who all make the center work well. And our aim is to look after patients and do the technical work that we need to do, but also make people feel comfortable in the environment. So infertility is defined as an inability to conceive after 12 months of unprotected intercourse. And the reason that there's a strict definition about when we should help patients is because the natural fertility chance per month is not actually that high. If everything is fine, the chance of conceiving per month is only about 15 to 20%. And we need to wait a bit of time for natural conception to occur. If nothing's happened after 1 year, then it's justifiable for us to start testing couples and offering treatment for them. So this is the reason that we wait the 12 months. If we look in general at all the causes of infertility, it's basically divided into 1/3 female, 1/3 male, and 1/3 is a bit of mixture between the two partners that are causing fertility problems. And as I said, it can be distressing for couples. People don't expect to have to go to fertility clinics to have children, and they expect once they, trying to have a baby, everything will be easy. But sometimes these things do occur, and so we have technology these days that can really help a lot of couples have their dream of having a child. So in this talk, I'll talk a little bit about the causes of infertility, how we assess a patient, and how we interpret the semen analysis, and explain what treatments we do for patients as well. So one of the common questions is what lifestyle things can cause infertility. The sperm is actually quite strong. It's pretty bulletproof. So you have to be quite sort of extreme in your lifestyle to cause an effect. But it has been shown that if you drink excessive amounts of alcohol and you smoke a lot, this can damage sperm. The narcotic drugs like cannabis and opiates can also damage sperm. Quite a lot of people use injectable testosterone when they want to get big muscles in gym. And if you inject testosterone, this will basically switch off sperm production. So we get quite a lot of people that are doing training and are taking testosterone or products that are similar to that. And that's they'll actually get azoospermia, no sperm in their ejaculate when they're taking these things. The good news is it's quite reversible. So if you stop it, the sperm will return to normal. There's lots of publications about if you're wearing tight underwear, it will elevate your testes and push them close to your body, which will heat up the testes, because the testes hang underneath this growth, underneath the body, because it's cooler, the temperature is cooler, and that's perfect for sperm production. So if you wear tight underwear and it pulls the testes close to the body, it heats it up, and it's not great for sperm production. So sometimes this could be a factor if somebody had a bit of borderline semen analysis. And some people worry about a warm laptop on your lap. But these things, a lot of the time, they're not major factors. And when people have real problems with their semen analysis, it's often, a more biological reason. So in the environment, there are also things that can affect sperm. There's certain pesticides, organophosphates, that can definitely damage sperm. The occupational toxins that people work with, sometimes in their jobs, lead, mercury, and cadmium. There's environmental toxins. What's quite interesting is the fluorinated substances that can be found sometimes in drinking water. So they've done tests in river water, and they sometimes find these chemicals in river water. They're estrogen-like compounds and anti-testosterone compounds in river water as well. These may come from contraceptives and end up in river water and so on. And this sometimes gets into the water supply and can reduce sperm production. It's also been shown that there's certain compounds in plastic called BPA, bisphenol A, and phthalates, which also affect sperm production. So there are some potential causes in the environment which are bad for sperm. This can sometimes contribute to decline in global sperm counts. There can be problems also of sexual dysfunction. This means that there's enough sperm in the actual sample, but the person is unable to have normal sexual intercourse, and this will basically obviously make it difficult for the couple to get pregnant. And those would be erectile dysfunction or premature ejaculation or inability to have an orgasm. So sometimes couples come to us and we need to send them to a sexologist or a urologist to sort these problems out. There can be medical problems as well, aside from sexual dysfunction. So some people have diabetes, thyroid disease, kidney or liver failure. These things, when people have serious medical conditions, often the sperm function will decrease as well. So sometimes we have to tend to the medical condition and improve it, and then the person's fertility will also improve. And chemotherapy is a well-known problem with damaging sperm. It's very toxic to sperm. So people who have cancer treatment very often can have problems with their sperm function afterwards. There are also genetic causes for sperm dysfunction, and Klinefelter syndrome is when a person's got an extra X chromosome, they're born with that, and they'll have certain physical function characteristics, but it can also decrease their sperm. Contagious syndrome is another one. And some people have got the actual tube that goes from the testis to the penis, the vas deferens, is actually absent. They're born without it. And this is a genetic problem, and it's also associated with the cystic fibrosis gene. And probably what's most written about genetically is a thing called a microdeletion or a mutation of the Y chromosome. So in men, the Y chromosome codes for sperm production, and some people have got little bits of DNA deleted off their Y chromosome. And this causes an inability to produce sperm normally. And we can test, people and see if they have this problem. So on the Y chromosome, there's a certain gene, and it's divided into 3 regions. AZF means azospermic factor, which means you've got no sperm, and it's basically divided into an A, a B, and a C region. But it's important for us because if we check and a person's got a deletion of the A or B region, there's no chance of finding sperm in that person. Even if we operate on the testicle and try and extract sperm, we can't find any. Whereas if people have got a problem with the AZFC region, we can actually do an operation on the testis and extract sperm that we can use for IVF. If we use that person's sperm and we make a child and it's a boy, that boy will have the same problem as the father. So the child will be okay physically and healthy and all the rest of it, but the child will have the same problem in that they will need fertility treatment as well. And there can be other acquired problems that you're not born with, but you get them during life. And that can be, for example, the sexually transmitted infections like gonorrhea, chlamydia, and so on. They can block the epididymis, so the sperm can't get out. You can get a mumps virus, and mumps can cause orchitis, which is swelling of the testicles. And most people, young boys that get mumps, they know they have it because their testicles get quite painful. But orchitis can actually damage the cells that produce sperm, and some people who have mumps have then the sperm problems afterwards. It's also possible sometimes that the testis can be twisted or torsion of the testis, and this can damage it and cause problems with sperm production. And the other physical thing is a varicocele. A varicocele is a dilated vein around the testis, and it's very common, but the increased heat from the varicocele and the increased blood flow around the testis can reduce sperm function as well. And then there's other medical conditions where there can be a problem inside the brain and the pituitary gland that's supposed to make hormone called FSH to grow sperm. There's a condition that people are born with called Kallmann syndrome where they don't have that hormone. We can actually fix that quite easily with injections. Some people have got a little tumor called a prolactinoma that also interferes with the functioning of that gland. And some people have actually had surgery on their brain to remove a pituitary tumor, and it's damaged basically, and they need medical treatment afterwards. Now, some people are born with testicular failure from birth, and very often actually you can't find the reason that the testicular failure occurred. So some patients we don't find it. Some patients we'll find the genetic causes, as I've mentioned, and it can also be associated with undescended testis. So some boys, when they're born, their testis doesn't descend into the scrotum, and they often have problems with sperm production. And undescended testes have also got a risk of getting cancer, testicular cancer. So normally when a baby's born, the pediatrician will feel in the scrotum and see if the testis is there. And also when a child is a bit older, they have to double check that the testis is in fact in the scrotum. Otherwise, it should be removed to prevent testicular cancer. People worry about testicular trauma, and almost all our patients can remember when they've had someone kick them in the testis or something like that. But most of those trauma events actually don't do anything, so they don't normally affect the testis unless it's really severe. So when we see a patient, what do we do? If we examine the patient, we will check the size of the testis. There's some little round markers to show the normal testis of the size of the testis, but the normal testis is about 15 mils, so about 5 centimeters in size. We will check to see that the vas deferens is there, that the tube from the testis taking the sperm out is present, and we will check for the varicocele whether there's any dilated blood vessels. Sorry. Okay. Then the investigations that we would do a semen analysis, which is basically a sperm sample that we can check under the microscope. We would do blood hormone testing, and there we check the FSH and LH that control sperm production, and prolactin, because some people grow a little tumor in their brain that can also affect sperm production. And we check the testosterone from the testis to make sure the testis is producing sufficient testosterone. In men with very low sperm counts, we will do genetic testing and look for all those genetic reasons why there may be no sperm being produced. So the semen analysis, what do we look for as doctors? There's a whole lot of things that are checked in the sperm, and we use the World Health Organization criteria, which was developed in 2010. And the way it was developed was quite interesting. They took a fertile population, meaning that they knew could have children, and they took the bottom 5%. And they said, that's basically where we see the cutoff in terms of what is normal. So they took fertile controls, and if you were in the lower 5% of the population, then it was considered that you had low fertility. And some of the main ones here would be the sperm count. It should be 15 million sperm per mole. So in every milliliter of sperm, there's supposed to be 15 million sperm. Then we look at the motility, the movement, the 40%, and we look at the shape as well, called the morphology. Now, in the past, we used to just use an embryologist, a person looking under a microscope, but these days we have computer-assisted semen analysis. So there's actually a computer that looks at the sperm, because this computer can track millions of sperm moving and accurately work out, whether the sperm is moving, whether it's just wiggling, or whether it's moving in the right direction, what we call forward progression. So the modern computers actually are very helpful at giving us a lot of detail about the semen analysis. So if people have low sperm count, we call it oligospermia, which means less than 15 million. If they've got no sperm, we call it azospermia. And severe sperm would basically be less than 1 million. There's also a new test that we can do on the sperm, which is interesting. It's not just looking at the sample and seeing how much sperm is in there. It's now looking at DNA fragmentation or problems with the DNA of the sperm. Because we know in some people, the actual numbers of sperm seem to be okay, but when you analyze the DNA by various tests, it seems to be damaged or fragmented. And there are quite a lot of reasons why this can happen. And this is where lifestyle might come into the picture. For example, smoking, drugs, pollutants, varicocele, advanced age, infection, fever, cancer, diabetes, obesity, elevated testicular temperature, and poor diet. All these things can affect the DNA of the sperm. And we sometimes do this extra test to give us more information about whether the sperm is definitely normal or not. If there are mild changes in DNA fragmentation, you can correct it. So you can fix the lifestyle problems. And we can do simple treatments called intrauterine insemination, where we place the sperm inside the uterus of the woman when she's ovulating, which is a fairly simple treatment to do. And if somebody's got a varicocele, which is a dilated veins around the testis, we can ask the urologist to do a varicocelectomy to remove the varicocele. The problem with the varicocele repair is it shouldn't be done in everybody, because it only seems to work in a certain number of people and also at certain sperm concentrations. So it's quite a common problem, this varicocele is present in up to 15% of the normal population. And it's important to do if the man's sample's a little bit bad, like suboptimal, but with a normal female partner. If the female partner's got serious problems and you're going to do IVF, then there's not much point fixing the varicocele, because you only need a couple of sperm to do the IVF treatment in any case. So we don't fix it in every patient. So what do we do if there's a really serious problem with the sperm or severe male factor? We do a procedure called IVF. IVF means in vitro fertilization, which means we extract the eggs from the woman and we fertilize it with a single sperm. So a single sperm is injected into each egg in the laboratory, and the eggs are then grown into embryos, and we place the embryos into the womb. So this can be done even if there's very few sperm in the male partner. It was actually developed in Belgium in 1991. As usual with medicine, many things are discovered by accident. And they were trying to inject sperm just under the shell of the egg, but the one student made a mess and injected it right into the middle of the egg called the cytoplasm. And they scolded him, but they found out the next day that his eggs were growing beautifully. And they repeated the procedure and found that this was an amazing technique, and you could in fact use it for men with poor sperm. So since the 1990s, we've had an excellent way of helping men who've got very low sperm counts. This is a picture of how we would inject a sperm into an egg. So you can see there's like a little holding pipette holding the egg in place, and then a glass needle is inserted into the egg and a tiny sperm is injected. Now, does IVF work? This is some data from the biggest database in the United States called SART. And it shows if you have a patient under 35 years of age and you just do one IVF treatment and you include all the embryos that the patient gets, we just tend to transfer one embryo at a time these days, but you often get extra frozen embryos from the treatment and you can transfer these as well. If you use all the embryos, then you can get up to 68% pregnancy rate just from one egg retrieval. So IVF has become a very successful treatment, but you can see as a woman gets older, the pregnancy rates will decrease. This is due to decreasing quality of the eggs. So in patients who've got no sperm in the ejaculate, so if we do a semen analysis and there's no sperm, what we would do is we would do an operation called a testicular biopsy. So we make the man sleep and we do a small incision on the testis and take out a tiny little piece of tissue from there. And that tissue is opened up with little micro needles in the laboratory, and we can find the sperm cells within the little tubules. We then freeze that sperm, and that we can use it then for IVF treatment going forward. In some cases, if we can't find any sperm in the testis, then we have the ability of using donor sperm. So this is a picture of a testicular biopsy here, where we open the skin, and then you can see the testis there, and we're opening the testis. That yellow tissue is actually the little tubules inside, and we can extract the sperm from there and then inject it into the egg. This is a technique called microdissection. It's similar, but we use our operating microscope, and there we can actually see individual little tubules that have got sperm in them to identify which sections of the testis might have sperm. In some men, they've got a medical problem where their pituitary gland doesn't work. And in those people, we can actually fix the problem with medication. So those patients, we would give them injections of HCG first to increase their testosterone levels back to normal. And then we'll inject them with FSH and LH, which will actually make sperm production in the testis. And this, the patient doesn't need IVF treatment. We can give them medication and then they can get pregnant naturally at home. Now, sometimes medications are used in men with low sperm counts to see if it can be helpful. For many years, it wasn't clear that these medications made any difference. But some recent studies have suggested it might be useful, and those medications are called clomiphene citrate and letrozole. They seem to work the best if the testosterone level is a bit low in the man, because they improve the testosterone level, and this sometimes helps with sperm production. It does take quite a while to work. It sometimes takes 6 months before you can see a decent effect. So it depends on how long you've got. And you have to, it doesn't work in everybody. You probably have to treat about 10 patients to get one pregnancy. So the medication, it does have usefulness if a patient is unable to do IVF treatment, but it takes a little bit of time and it's not often as successful as IVF. If there's no sperm found in the ejaculate and we're unable to get any sperm from a testicular biopsy, we do have the option of donor sperm insemination. And sperm donors are screened as according to the National Health Act in South Africa, and the sperm is then frozen for 6 months, and the sperm donors are retested again to make sure they don't have any infectious diseases. And then basically we can proceed and use their sperm to help patients get pregnant. The screening that we would do on sperm donors, they would have a medical assessment with the doctor first to go through their medical history and their family history. They would have a psychological assessment with a psychologist, and then they would do all the different tests for sexually transmitted diseases. And then we freeze the sperm and we recheck them for HIV again after 3 months just to make sure they're not in the window period. In South Africa, the sperm donors are largely anonymous. And so their sperm would be looked after at a clinic sperm bank. And once the donor reaches 6 live births, the donor would be withdrawn according to the current law. So Saskia also asked me just to talk a little bit about COVID and let you know whether that had any effect on male infertility. It's obviously a very topical subject at the moment. So the virus is called SARS-CoV-2 that causes the disease COVID. And basically it binds to receptors on human cells called the ACE receptor. And that stands for angiotensin converting enzyme. And it's an enzyme involved in things like fluid balance and blood pressure. And it's present in many different tissues in the body. And one of those tissues is in fact testicular tissue. So there's quite a lot of ACE receptors within the testicular tissue. It seems like these are used for fluid balance within the actual testis to regulate the fluid around the tubules to optimize it for sperm production. And if they look in the different cells in the testis, they can find these ACE receptors in the Leydig cells that are related to hormone production, and the Sertoli cells, which are like the tubules where the sperm is made. And when they've looked in people who have died of COVID, patients who've died and they've done a post-mortem, they actually find inflammatory changes in the testis. So it seems like the COVID virus definitely can infect the testis and cause problems there. Interestingly, in patients who recover from COVID, if they asked questions, about 90% of them actually report some scrotal discomfort. So perhaps there was a degree of inflammation in their testis as well. So what they find in terms of sperm function is in some studies, basically, they can actually detect the RNA. So if you do like a sample of the sperm, you can actually pick up the RNA from the virus, from the COVID within the sperm. And there is evidence of decreased spermatogenesis on the semen analysis in quite a lot of the patients who are recovering from COVID. There's no evidence that this makes any difference to a future pregnancy at this point, so it doesn't seem to be dangerous, but it seems like it could impact on male fertility. Thank you very much for listening to my talk, and I look forward to hearing the next speaker and answering any questions. Thank you so much.
Thank you, Dr. Le Roux. We appreciate the fact that you're always so willing to give your time and expertise to our campaigns. And there are a few questions in the question and answer section, so I'll go through them with you after our next speaker. So our next speaker is Chris Lawson. Chris and his wife went through 5 years of trying countless IVFs and 18 embryos before their daughter Rosie was born in January 2020. He also runs a podcast called IVF Dad, which has 8 episodes available so far. He's going to have a chat to you about his journey and where you can find his podcast and why he felt the need to start it. Welcome, Chris. All the way from
Saskia. How are you?
All the way from not so sunny UK.
It's snowing at the moment, actually.
Oh, see, it's not very sunny in Joburg either, so I don't feel too bad for you.
Oh, well, there we go. There we go. Well, look, it's great to be here and absolutely fascinating. Thank you, Dr. Le Roux. I wish I'd heard something like that when I was starting on the journey. And, for a start, I'd just like to, sort of say thank you for inviting me. It's great to be here and also great that so many people are taking the interest to find out about infertility, because I think that was one of the things that struck me, that it really almost crept up on me. As Saskia said in the introduction, we left it pretty late to start trying for kids. I was 44 at the time. My wife was 39. She was my girlfriend at the time. And it's one of those things that when you meet someone later on in life, you do sort of just know, and you can just go, right, do you know what? We can get on with it now. We both wanted kids, so let's get on. But what we didn't just know was how hard that journey was. And I was in a situation, my granddad, he had 8 kids, and he had 2 of his kids in his 70s. So he had my dad when he was 76, and he had his last kid at 79. So I pretty much went through a lot of my life thinking, well, you can just carry on having kids as a bloke, can't you? It would just carry on, and not understanding that there were decisions that I was making, or the fact that we do have a biological clock, and it might not tick nearly as fast as for females, but there is still a biological clock getting on. So we started out our journey. We tried for a year and more with no luck, and then we decided that we'd go and get treatment and see what was needed. And 5 roller coaster years. I mean, it really was a massive journey. There was heartache, there was pain, there was wacky diets, there was superstitions, there was facts, there was fiction, there was hope, there was complete loss of faith. And I think one of the things that sort of struck me as you sort of go through it is the fact that it's hard to know where to turn. And I think it's a relatively female orientated world. I think one of the things that struck me was that I was sat in a waiting room and there was 9 females there waiting for their appointments. And I'm looking around and there's one other guy and he's got his head in his phone and I've got the head in my phone. And I just thought, this is a really lonely place. And where do I go for support? So I vowed that if I was successful, and luckily we were, with Rosie being born last January, that I would try and put that right and shine a spotlight on some of the issues and the challenges that we face as being the male partner. Because I was struck there wasn't that much support aimed at a partner who is usually male. And yet we're equally important in the process, or are we? And that, I think, is one of the challenges. As Dr. Paul said, when you look at it, over 50% of the reasons why there is a fertility issue can be male related. Yet, interestingly, a lot of the fertility treatment and fertility support all seems to be female orientated. And as I started out on our journey, I think one of the things that sort of struck me, the most challenging bit to start off with is you can go into that consultation with your partner and you're sat down, and it can be quite a nerve-wracking experience. And I thought the explanation we just had about fertility was really, really clear, but it's quite hard to find that sort of stuff on the internet. And I've sat down and I'm arms folded as they're taking to Trish's medical history. And then the spotlight turned onto me. It's like, right, well, we need to get you tested as well. And it's an interesting process. It's not a particularly sort of a glamorous process and enjoyable one. But then when I'm looking at the sperm test results and I'm looking at some of the figures that sort of Doctor put up before, looking at how I compared to some of the benchmarks, and my morphology was 2% and my sperm per the sample was 11 million. So I was in that sort of could do better category, not absolutely disastrous, but actually I would need some help, some support in order to conceive children. And again, you look at something like 2% morphology and you think, what, I've only got 2% normally shaped sperm. That just sounds absolutely terrible. Until you understand that the average is more like 4 or 5%. And that as a comparison doesn't seem nearly as bad as saying, right, well, what, 2% and the natural average is 100 or something like that. So I think understanding and being aware of those benchmarks and being aware of the different nature of the sort of sperm test is incredibly important. And that's what I've tried to outline in some of the episodes of IVF Dad. And I've got a doctor to talk through those sperm test results and take us through that. I think the other fascinating thing as I started going through this process is, so what is your role as the male partner throughout this? As I said, when we looked at it, the reason why we weren't conceiving was a bit of me and a bit of Trish. And we knew that we needed some help. So they advised us and recommended us to have something called ICSI treatment. And basically what that is it's a process where they select the best sperm. So rather than putting the sample back in to fertilize the egg on a sort of a test tube, they select the one sperm, and that's a great treatment if you have got sort of less than sort of great sort of sperm, because they can find them. And of course, it only takes one. And I think that's a really, really important point out of all of this, is that out of all of the stats you might hear as you go through fertility treatment, as in, I've got 13 eggs and 11 fertilized, and now we've got 4 or 5 blastocysts, or I've only got 3 million sperm, or even I've heard stories of people only having as little as sort of 30 or 40 sperm. It only takes one sperm and one egg to combine to create one successful blastocyst, and then you can be lucky and have your child. And for us, as we followed that through, we went through so much heartache as we tried and tried and tried again. And I think your role as the male partner, you almost imagine that is like team coach. You're there for motivation. You're there to go, come on, you know, we're doing good. I know you're going to have to be injected again. I know you've got to take another round of drugs, but we just got to get through this bit, and we'll make it through to the next stage. And I think this is something that is important to reflect on, which is it's not also about the physical burden, which once you go past through the testing and understand sort of male factor infertility, and hopefully that can be treated, and you get on your journey to sort of working out how you can conceive via IVF, it's the mental burden as well. And having a situation where you can get your hopes up for them not to come true, and then having to dust yourself off and pick yourself up and try again and again and again can be absolutely exhausting. And it can be absolutely exhausting if you see your role as the only role that you've got is about maintaining that motivation and being there for your wife or your partner, because you need to be there for yourself as well. Because there is no point having a team coach if your team coach is exhausted. And this takes a mental toll on you, whether you're a female or the male partner in this. And I thought that was a really important point to reflect on, that this is a mental burden as well as potentially a physical burden. I think the other challenge as well, which is of course worth talking through, is that this is a financial burden as well. I know the sort of it's different in South Africa to it is in the UK. You can get some fertility treatment in the UK. We had to go privately because we were over 40. And of course, what you're trying to do is weigh up the chances of success, the statistics that the doctors will give you versus your bank balance, and knowing that when they say, well, it's potentially a 15% chance that it can happen, and but if we can do this procedure, we can increase it to X% chance. It's like roulette. You're putting all of your money on sort of one of the numbers, and you're hoping that it can come true. And of course, dreams can come true, and it's important to hold on to that fact. But it's also to have some practical realism in there, and understand that there's a limit to what you can do sometimes. We had to make some massive lifestyle choices. We didn't go on holiday. I'm still driving the same car that I was driving in 2003. Trish had been saving a deposit for a house, and that all went pretty much on fertility treatment. My Uncle Terry died, and I put all of the money he left me in the will towards fertility treatment. And the bottom line is that I look back on that now, and I am so glad that I made those choices, because we were going through a situation where we really didn't think that it was going to be possible for us to have children. And our dream did come true. But it took heartache, it took pain, and it took some tough choices. And I'm very aware that for some couples, they have to change their dream. And I don't think it's about giving up on your dream. I think it's very much about changing your dream. Because when we were looking at it, we'd gone through about 6-7 rounds. We'd got to about sort of 14, 15 embryos. And the doctor had sat us down, and the file notes are now that big. And when we walked in, they were that big. And she said, look, I think the reality is that we need to be looking at egg donation or sperm donation as the next round to help you get the family that you want. And at that point, it was incredibly difficult because we'd had every single test that there was. I'd had the DNA fragmentation test, and that shown that there wasn't too much going wrong there. I'd improved my lifestyle, thought about some of the elements, even had another sperm test, and actually the results had improved over that time. Trish likewise was carrying out sort of more tests, and they were saying, look, you are getting great results, but unfortunately, the embryos are not implanting, and therefore we think for you to have a family that you're going to need to move to egg donation or sperm donation. It's a really tough point of that, because it makes you really think what a family is. We went to counselling together, which the hospital provided. And at first I was incredibly angry because I go, well, why can't I have my cake and eat it? I'm getting on at this point. All my friends have got, some of them have got 18-year-old kids, and I still haven't got one. And really, I wanted to see a piece of myself and a piece of Trish in our prospective kids. I wanted to look at them and do that. But do you know what? As soon as I managed to get angry about that and understand what I really wanted, I was also able to try and let go of that, really. And we sort of started to think about it a bit more creatively and understand that what was important was creating a family. And I was brought up with a stepdad and stepbrother and stepsister. I don't ask them about their biology. I don't think about them about what genetics they've got. They're just my brother and sister. Now, as it was for us, we had one embryo left in the freezer. And it wasn't a very, very good quality embryo, but we had sent it off for genetic testing, and it come back that actually the genetics of this embryo were okay. And so we sat down with a doctor, and she's saying, right, well, we think that we need to move to egg donation, but remember, we've got one left in freezer, so let's put it back and see what happens. And in a way, I'm down the pub with my best mate, and I'm almost managing expectations, because I've had to manage expectations a long time. And I go, well, look, we're trying again, but if this doesn't really work, then we're going to move to egg donation, almost assuming that would happen. And that was the embryo that was successful. And obviously 9 months later, we have a beautiful daughter. But what did I learn out of that process? I think what I learned was that it can be an incredibly lonely place. And this is one of the bravest journeys that you can go through. And equip yourself with knowledge. Do what I didn't do, which is attend a webinar like this, so you understand the process and you understand some of the things that you can do. And you work out what is fact and fiction. I was unaware about the impact of smoking. Yeah, I was really aware of what cycling could do or wearing sort of underwear. Yet they're minor factors of smoking. So make sure you work out what's in proportion and what's important. And then I think the other thing that's really important is to look after yourself, is also to look after your team, your family team. So don't put all of the efforts on the female partner, who is going through a huge burden, that physical burden as well as the mental burden. But they need you to be both strong and emotional, to show your weakness as well as your strength, and to keep the faith and to keep going, but also to understand that actually sometimes you need to think about creatively, and you need to think about a new path as well. So as I said, thankfully, Rosie came along, and I looked around and I thought, I want to give back. I want to do something that gives back, and I want to share the journey that I've been on, with a hope that it helps other people, females and males, understand it from a male perspective going through IVF, because there's 1,000 Instagram accounts out there, which are mainly female focused, but not much from a male perspective. So I set up ivfdad.com. So that's ivfdad.com, as it says. You can find the podcast on there. I've recorded 13 episodes where it really tries to take you through that whole journey, through from that first consultation through to understanding what it's like to face the fact that sadly you've had a miscarriage, and how to deal with it, through to how do you dust yourself off and try treatment again, and looking at adoption and donors and the like, through to how you actually manage that really anxious time after so many years of treatment when you get pregnant and the pressure that puts in. And it's great, getting great response both in the UK and internationally now. So I'd love you to check it out. It's there to help people through the process and provide empathy from a male perspective. But it's just great to be here, and thank you very much for inviting me. And I really sort of appreciate that, and I hope that story's helped brought some of the challenges to life somewhat.
Thank you, Chris. That was great. We really do appreciate you being here and giving, it's afternoon your side, so giving up time in your afternoon.
Pleasure.
And thank you for sharing your story with us, and also for doing what you're doing with your podcast. It's great. We're going to share the details on our social media pages after the webinar, and I'm sure you'll get many more people coming on board from the South than you have at the moment. We have got some questions for you as well in the Q&A, so I'm going to go through those now. First of all, we're going to start with Paul Le Roux.
Saskia, before you talk, can I just say something quickly? Chris, I just wanted to say thank you very much for your talk. I think what you're doing, is extremely inspiring for a lot of couples. And, I think we know that a lot of people feel comfortable sitting at home and watching, a podcast or something. And when a patient does it who's been through these things, it really makes people feel much more at ease when they're going for treatment. And as you say, there aren't actually so many good things that men can look at, to help them through the journey. And I think the way that you've explained the things that you've done today is wonderful. I mean, you've picked on so many of the really important aspects of what couples go through. And I think it's really invaluable. So, I'm so glad that you got your baby in the end after all the IVF treatments. So well done for being brave and going through all that tough journey. But I mean, I really congratulate you on setting up this IVF dad thing. And I'm very sure it's going to actually make a huge influence on many patients. So thank you so much.
Thank you. That means a lot.
Ah, that's great. Thank you, Dr. Le Roux. Okay, so Dr. Le Roux, the first question's for you. Does hormone replacement therapy affect sperm production?
Yes. So most of the time when people are having hormone replacement therapy, they're actually having testosterone replacement. So there's some men who have testicular failure from when they're young, and the urologist will give them testosterone medication. So some people, they're on hormone replacement from a young age, and very often they actually don't have any sperm in their testes because they've got testicular failure from when they're young. And then you get older people who also go to a urologist. They might be 40 or 50 years old. Somebody does a blood test on them and finds that their testosterone is a little bit low. So they're given testosterone to try and help with their sex drive or to make them feel more energetic. And this will definitely suppress sperm function as well. So you have to be very careful in terms of testosterone replacement in men.
Thank you. And then blood hormone testing is routinely performed to test pituitary hormones and certainly or Leydig cell function. Why don't we use specific markers of sperm and seminal fluids? We would have better understanding and a better diagnosis.
So basically the hormones that control sperm function, the FSH from the pituitary gland is the hormone that stimulates sperm production, and the LH hormone from the pituitary stimulates testosterone production. Those are easily measured in the blood, so it can give an indication basically what's going on in the testis. If the testis is not functioning properly, you get feedback mechanisms to the pituitary, and that will affect those pituitary hormones. So it's a very simple, easy test to do. I mean, you can obviously test the sperm itself, which is like with a semen analysis. And obviously, people have looked at the various markers in the sperm, but the only things that really are clinically useful at the moment, are the blood markers, and then within sperm doing DNA fragmentation and so on. There's lots of things done in research settings, but I don't think these have translated into giving us real idea in terms of changing our management. Yeah.
And the last one for you, Dr. Le Roux, is we hear people either refer to sperm as sperm or semen. What is the difference?
The sperm is actually the cell, and the semen is all the fluid and everything else. So when you're doing a semen analysis, because you analyzing the fluid that the person has ejaculated, that's the semen. And within the semen, there will be sperm, there'll be fluid, sometimes other cells like white blood cells. And there's obviously various proteins and things within the semen. So the semen analysis, they're looking at a whole bunch of things like the volume of the fluid, the viscosity of the fluid, whether there's other cells in it. And then part of that will be actually counting the actual sperm cells within the fluid. Yeah.
Great, thank you. And Chris, this is for you. It's from Bradley. He wants to know, did you have an external emotional support system to help you through the process? And how did your journey impact your relationship emotionally?
Wow, two great questions there. The answer is yes. What was really interesting was that my mates are great, and if I wanted to talk about fertility, I'm sure I could have done, but quite often I wanted to just sort of go away and forget about it. Yet it is important to have a system where it is focused on you, especially in this journey when so much of your energy is being focused on your partner as well. And therefore I think it's really, really important to have that emotional support system. And we talk a lot about sort of life coaches or mentors or counselors, and I don't think it really matters what it is, but I think it's really, really important that you find an outlet where you can discuss it. And in terms of how it impacted our relationship, I think one of the most important things that Trish and I decided was that actually we were our family. That was our relationship, and anything on top of that was going to be an absolute bonus and an absolute blessing. But it was really, really important that what we had was great, not something that was substandard or something that was incomplete. It was a base to build something else on, but what we had, we were lucky about, and we still feel like that. The second thing was I tried to make sure that even though I wasn't able to do the physical job, and the hormones can be horrible in some shape or form for the female partner, that I was there as much as I could be. So I attended the scans, even though it meant that I was pretty much sort of useless when she was off getting blood tests and the like. And I also helped inject her until she got tired of me injecting her. And I think it's important that you see it as a team effort, because then you can build that relationship around you. But you're going to go through everything. You're going to go through anger. You're going to go through guilt. And it's important to let those emotions out, but to understand that it doesn't have to destruct your relationship at the same time.
That's very true. And it's obviously very real for a lot of people on this webinar, because you were asked that 3 times. You asked that question, and there's 2 further questions asking about how it affected your relationship. So it's something that's very important. And I also agree with what you said. The same thing for us, for me, myself and my husband. We also agreed that we married each other for each other, not for the children that we could give each other. So we were in it together. And when people would ask us what our issue was when they found out that we couldn't have children, we would say it's our issue, not that it was his or mine, or because it is, you're a team. So
absolutely,
it's your issue. And I think that really helped the guilt, because he was feeling guilty. Then when I also had issues, I felt guilty. And then when we both sat and said, it's our issue, because it's a couple issue. So it alleviated a lot of the guilt.
I think that's an important point, because there's a certain amount about helplessness here. I think, there's a helplessness as a couple where you can't get to where you want to get to. And then as a guy, there's also helplessness in terms like you can't do the practical job, you can't do the physical job. And I think dealing with those emotions of helplessness is an important part of it, and being able to talk to your partner about it, about, do you know what, I'm just feeling a bit useless at the moment. I'm feeling like actually I can't really do a lot, and you're having to do it. I think was an important part for Trish and I, because she goes, I'm glad you said that, because actually I thought you were just bulldozing through it and weren't showing enough emotion and being really strong, and she actually wanted to see some of that vulnerability. So, you know, it's amazing what you learn really on that journey.
Definitely. So thank you. And there's also another comment about the fact that the stigma in South Africa with regards to male infertility is big, and it really is. There's some feedback. Chris, what a great talk. Thanks for sharing. And then another one, Chris and Dr. Le Roux, wonderful talk. Thank you. And the final one is, what an inspiring webinar, makes things easier. Thank you all. It's so sad that as men, we need to remain anonymous because of the stigma attached to being infertile.
Yeah. Yeah, well, that's hopefully we can do something about it. The more we start the conversation and bring that out into the public, I'm convinced it will get better. And why should we be embarrassed about this? There's nothing to be embarrassed about.
It's exactly, it's a disease.
Mm.
So no, I agree. Thank you. Thank you, Chris. Thank you to Dr. Le Roux. And thank you to everybody for joining us on our third webinar.
And to you, Saskia and Lucia as well. Thank you very much for inviting me. I think it's an excellent initiative you're putting on there with your respective organisations.
Thank you. No, we appreciate that. So thanks to everybody for joining us. On Thursday, we're going to be online again at 6 o'clock, talking all about pregnancy and COVID-19 times, what to expect at scans, etc. And we'll also be touching on whether having the vaccine while pregnant or trying to conceive affects your baby or your fertility. So please do register at reproductivehealthmonth.co.za. This webinar will be available tomorrow on our YouTube channel, on the AFASA YouTube channel, as a recording. So please feel free to share it with your family, your friends. If some people don't understand what you're going through, etc., this maybe can help them. So thank you, Dr. Le Roux, again, and thank you to Chris for giving up your time. We do appreciate it.
All right. Bye-bye, everyone.
Take care. Stay healthy, everyone. Bye.
Bye.